Hello everyone. Today we will be quickly going through 25 MCQs from the subject of neonatology. A late preterm newborn developed respiratory distress. Which of the following is in favor of RDS? So the options are history of antenatal steroids, air bronchogram on chest X-ray, onset of distress at 12 hours of birth, and term birth. Now this baby is already late preterm newborn. So term birth, this is out. This option is out. Onset of distress at 12 hours of birth, no, that's quite late. Air bronchogram on chest X-ray, yes, this is a finding in RDS. And history of antenatal steroids, no, this is not the answer because antenatal steroids are in fact protective of RDS. So, which one is in favor of RDS? The right option should be air bronchogram on chest X-ray. Option B is the right answer, air bronchogram on chest X-ray. A term baby developed jaundice on day 3 of life up to thighs. He is passing normal urine and stools. Mother's blood group is O positive, baby is A positive. The cause of jaundice is. Now here the options are Rh incompatibility, physiological jaundice, biliary atresia and sepsis. Now in this question, the jaundice is occurring on day 3 of life, it's up to the thighs. The baby is passing normal urine and stools. But mother as well as baby are Rh positive, so Rh incompatibility is not the answer. Physiological jaundice, yes, day 3 of life, jaundice is up to the thighs. Okay, so physiological jaundice is most likely the answer. Biliary atresia, no, because the stools are normal in color. And sepsis also unlikely because they have not mentioned any other feature in the question stating that this baby is sick. So all the things mentioned in this question are in favor of physiological jaundice, and that's the right answer. Infants of diabetic mothers have hyponatremia, hypocalcemia, hypothyroidism and hyperglycemia. Okay, so infants of diabetic mothers, they do have hyperglycemia in the fetal period and increased insulin secretion. Yes, they do have that. But when they are born, when they are in the newborn period, the initial few hours there is risk of hypoglycemia. So this answer is not the answer. Hypothyroidism not directly associated with IDM. Hypocalcemia, yes, this is one of the most common metabolic problems in IDM because of functional hypoparathyroidism. And hyponatremia, no. So infants of diabetic mothers have hypocalcemia. This is the right answer. Vomiting on day 1 of birth may be due to all except pyloric stenosis, esophageal atresia, aerophagy and amniotic gastritis. Now pyloric stenosis is very rare before 4 weeks of life. Esophageal atresia is a congenital anomaly. Aerophagy, that is ingestion of air, that may lead to vomiting. Yes, this is a possibility. Amniotic gastritis, yes, it is a known possibility in newborns as a cause for vomiting. So pyloric stenosis, if the baby has vomiting on day 1 of life, pyloric stenosis cannot be the answer. Okay, all the other 3 are possibilities. Jaundice seen soon after birth is due to, so here the clue is soon after birth. Sepsis, Rh incompatibility, breast milk jaundice and physiological jaundice. Now we all know physiological jaundice, this occurs on day 2 to 3 of life. Okay, 2 to 3 days of life. Okay, that's when the onset of physiologic jaundice is. Breast milk jaundice usually in the 2nd week of life. Rh incompatibility, yes, because this is going on since the fetal period. So this jaundice, Rh incompatibility leading to jaundice, that may be evident soon after birth. Sepsis, again, no. Sepsis induced jaundice, that will take time to appear, not as soon as Rh incompatibility. So here the most likely answer in this scenario is Rh incompatibility. Meconium contains all except lanugo, bacterial flora, epithelial debris and bilirubin. Now lanugo is there, bacterial flora no, because meconium is sterile. Okay, epithelial debris yes, and bilirubin yes. So bacterial flora is not a part of meconium. For a 2.5-month child, tachypnea is RR of more than. Okay, now we all know that till 2 months the RR, if it is more than 60 per minute, then it is tachypnea. Then 2 to 12 months, if the RR is more than 50 per minute, then it is tachypnea. And from 12 months, that is 1 year, to 5 years, if the RR is more than 40, then it is tachypnea. Now this is a child who is 2.5 months old, so the answer is more than 50 per minute of RR is tachypnea. Which of the following is not the correct sign of good attachment of a baby to the breast? Here you can see the options. Baby's mouth is wide open. Yes. Lower areola more visible. No, the areola should not be visible. Baby's lower lip everted. Yes. And baby's chin touching the breast. Yes. So like you can see in this picture, baby's chin is touching the breast. The lower lip is everted. The lower areola is not seen. Baby's mouth is wide open. Okay. So which is not the correct sign? Lower areola more visible. This is not the correct sign of good latch. Which of the following is the least important prognostic factor in congenital diaphragmatic hernia? Pulmonary hypertension, delay in surgery, size of the defect, and gestational age at diagnosis. Now, pulmonary hypertension, pulmonary hypoplasia, size of the defect, gestational age at diagnosis, all these influence the prognosis, but delay in surgery does not. Okay, it's not like once the baby is out and you operate, if you operate immediately, it's not like that will have a prognosis, because this is a congenital anomaly that's going on since the baby was formed in the womb. And the pulmonary hypoplasia, hypertension, all these are long standing effects, and they do have a role in prognosis of the disease. However, delay in surgery does not directly impact the prognosis, which is not a component of Apgar score. Now here you can see clearly the options are color, muscle tone, heart rate and respiratory rate. Now here you have to be careful. Respiration, yes, it is a factor, but respiratory rate, no. Okay, heart rate or pulse rate, yes. Okay, you know that it is absent, less than 100 and more than 100 for 0, 1 and 2 points respectively. Muscle tone is also one of the components of Apgar scoring system, and color or appearance is also one of the assessment factors, but respiratory rate is not a component of Apgar score. Okay, it's either absent respiration, slow and irregular respiration, or vigorous cry. During intubation of a newborn, use uncuffed tube with a straight blade. Okay, uncuffed tube with straight blade. This should be your answer. Atypical Moro reflex is seen in all except fracture clavicle, yes. Brachial plexus injury, yes. Shoulder dystocia, yes, if there is any injury impact on the shoulder. Sternomastoid tumor, no, this is a tumor or a sternomastoid muscle mass. So here this will not affect the Moro reflex. So this is the answer. Atypical Moro reflex may be seen in fracture clavicle, shoulder dystocia and brachial plexus injury, not in sternomastoid tumor. BPD or bronchopulmonary dysplasia is seen in all except oxygen toxicity, yes. Theophylline use, no, theophylline does not cause BPD. Traumatic damage to the lungs or barotrauma, yes. Pulmonary edema due to capillary leakage, yes. So BPD is not seen due to the use of theophylline, that is not a causative factor. Characteristic radiological feature of TTN in a newborn, transient tachypnea of newborn: reticulogranular appearance, low volume lungs, prominent horizontal fissure and air bronchogram. So here you can see the arrow pointing towards this white line. This is the fluid in the horizontal fissure, and this is a characteristic radiological feature of TTN, prominent horizontal fissure. The other three in this question, reticulogranular appearance, low volume lungs or poor expansion of lungs, and air bronchogram, all the other three, these are seen in RDS. But prominent horizontal fissure or fluid in the fissure is seen in TTN. Unconjugated hyperbilirubinemia is seen in all except. So we know that Crigler-Najjar and Gilbert syndrome, these two are unconjugated hyperbilirubinemia syndromes. G6PD deficiency also, again, it causes hemolysis and unconjugated hyperbilirubinemia. Dubin-Johnson causes conjugated hyperbilirubinemia. So this is the answer. Okay, unconjugated is seen in all the other three, and Dubin-Johnson shows conjugated hyperbilirubinemia. In unconjugated hyperbilirubinemia, the risk of kernicterus increases with the use of ceftriaxone, phenobarbital, ampicillin or sulfonamides. Here the answer is sulfonamides. Why? Because sulfa group of drugs, it reduces the activity of the UGT glucuronyl transferase enzyme. Okay, so sulfonamides increase the risk of kernicterus because they cause increased unconjugated bilirubin circulating in the blood, and that is why the risk of kernicterus increases. Phenobarbital rather is used to induce the enzyme, so this is not the answer. Sulfonamides can increase the risk. All of the following are true except physiological jaundice peaks after 48 hours. Yes. Breast milk jaundice peaks after day 7. Yes. High levels of conjugated bilirubin may cause kernicterus. No. High levels of unconjugated bilirubin or indirect bilirubin may cause kernicterus, because indirect bilirubin or unconjugated bilirubin crosses the blood-brain barrier and can get deposited in the basal ganglia, not the conjugated bilirubin. So this statement is wrong. Fetal alcohol syndrome is characterized by all except, so microcephaly, yes. Low intelligence or learning problems, intellectual disability may be seen in fetal alcohol syndrome. Septal defects in the heart, yes, this is one of the features in fetal alcohol syndrome. Large proportionate body, no, this is not a feature of fetal alcohol syndrome. The late features of kernicterus include all except hypotonia, sensory neural hearing loss, chorioathetosis and upward gaze palsy. Upward gaze palsy, chorioathetosis, sensory neural hearing loss, these are all features of kernicterus. Hypotonia is not a feature. Hypertonia is a feature of kernicterus. Increased tone is a feature of kernicterus. So here hypotonia is the wrong answer. This is not a feature of kernicterus. Which of the following malformation in a newborn is specific for maternal insulin dependent diabetes mellitus or overt diabetes? Now here you have to be careful. The options given are TGA, caudal regression, holoprosencephaly and meningomyelocele. Okay, so don't be in a rush and mark TGA. Read the question carefully. Which of the following malformations in a newborn is specific for maternal overt diabetes? Okay, the answer here is caudal regression or sacral agenesis. Okay, caudal regression syndrome. TGA will be the answer if the question is most common congenital heart disease in infant of diabetic mother. If that is the question, then you mark TGA. But if the question is regarding malformation in a newborn specific to maternal overt diabetes, you have to mark the answer caudal regression. Which is not a normal finding in a newborn? Systolic murmur, yes, it may be present usually in a closing PDA. Pulse rate of 90 per minute. Peripheral cyanosis, yes, in the immediate newborn period, acrocyanosis is normal. Irregular breathing, yes, it is a finding in newborn. Pulse rate of 90 per minute, okay, this exactly is not normal. Okay, usually the heart rate of a newborn is 120 to 160 in the immediate newborn period. This may be the heart rate. Pulse rate of 90 per minute, this requires evaluation and monitoring if this is persistent. Persistence of Moro reflex is abnormal beyond 6 months of age. Persistence of Moro beyond 6 months is abnormal. In asymmetrical IUGR, which organ is not affected? Okay, in asymmetrical IUGR, the brain is spared. Brain sparing effect is there. Brain is not affected. Neonatal period extends up to 28 days of life. 2 days after birth, baby developed respiratory distress and was noted to have scaphoid abdomen. Breath sounds were decreased on the left side. After bag and mask ventilation, ET tube was inserted and cardiac apex shifted to the right side. What should be the next step of management? Now here, first of all, this is a two-step question. First, you should know what diagnosis you are dealing with, and then you can fix the situation and answer this question, which is what should be the next step of management. Now the baby has developed respiratory distress, scaphoid abdomen is there, breath sounds are reduced on the left side, cardiac apex is shifted to the right side. Okay, so this is after bag and mask ventilation. All this is fitting into congenital diaphragmatic hernia, where the left side of the thorax is filled with the intestinal contents. Okay, and after they have given bag and mask ventilation and put the ET tube, now the heart has shifted to the right side. There is mediastinal shift to the right side. Okay, what should be the next step? Confirm the position of the ET tube, emergency surgery, NG tube and chest x-ray. So the answer here should be NG tube insertion, because that will decompress the intestines and the stomach, which is causing a mechanical obstruction in the thorax. Emergency surgery and chest x-ray and confirming the position of the ET tube, all these things have to be done, but the prime thing which needs to be done to correct the situation is NG tube insertion. And then you can also take a chest x-ray and plan for surgery once it is showing congenital diaphragmatic hernia. So that's all guys, that's all for today. Stay tuned for more such videos.